Hey, what's up everybody? Today we're going to talk about what you need to know, have, and do before going to a hospital, whether it's for COVID or another illness. I'm Risa Morimoto, your host, and you're watching Modern Aging, where we chat about innovative and holistic ways to optimize and elevate our health and well-being as we age. When you click on that little red button below that says subscribe on it with that little bell next to it, you'll always be sure to get notified whenever a new episode is uploaded. I want you to check out our website at thisismodernaging.com for news about our upcoming programs. I've had my fair share of crazy, awful experiences when my parents got sick and had to go to the hospital. Maybe you've had similar experiences. I interviewed hospitalist Dr. Beth Heuzey during the pre-COVID days about what we can do as families to make sure that our loved ones have a smoother stay and not get so frustrated by all the bureaucracy and miscommunication. Especially right now when so many people are going into the hospital and emotions are running really high, there are things that we can do. So I want you to check it out. Today we're going to talk about being a hospitalist and getting in and out of the hospital, how we can do it with a smoother transition. Yeah, as with the least amount of pain as possible.
Okay.
So tell me a little bit about where you work, what you do, and kind of what being a hospitalist is all about.
Sure. So being a hospitalist is like being a general internist who only works in the hospital. And it's here. It used to be that primary care physicians would come see their own patients in the hospital and make plans for them and do the management and be responsible for that. But as healthcare has shifted and changed, that's virtually impossible for one person to do. So this job of hospitalist exists. I happen to work with residents and students. Not all hospitalists do. Some are alone or some have physician's assistants helping them. And what it is we come into the hospital. It's a shift work kind of a job, and we're there for 8, 9, 12 hours during the day. And when we go home, another hospitalist takes over for our patients and we communicate what's been going on.
So you're the doctor we see when we're in the hospital?
If you are admitted to the hospital. A lot of people think that maybe I'm the doctor in the emergency room, but there are dedicated emergency room physicians who triage and say, oh, this person should be fine at home, or this person really needs to stay overnight. So once that decision has been made, then you might be admitted to my service, assuming you don't need surgery and you need medicine.
Does that mean you need to be kind of a jack of all trades? Like, do you
In a way, yes. You need to be aware of very common diagnoses and less common diagnoses for all patients admitted to the hospital. And one skill that you become good at is saying, okay, now this problem is bad enough that this person needs a specialist in that specialty, say cardiology as an example. So you're also the person who coordinates specialists much of the time.
So are there specialty hospitalists? Or those cardiologists who will just be,
By and large, there are not specialty hospitalists, although neurology hospitalists are coming to my hospital at least. So I think that is, and pediatric hospitalists are up and running. So I think that may become something in the future.
That's it. Why neurology?
I'm not sure. They have to be there for any strokes that happen right away, so that might just be logistically easier if they're on site and not having to drive from somewhere else.
So do you find that there are certain things that incoming patients or families kind of have misunderstandings about, or that they just should know about prior to coming to a hospital that would help create a smoother hospital stay?
I think part of the frustration of patients and physicians is well understood that there are so many people you have to speak with, and you don't realize how many people there are to care for one patient. The emergency room physician versus the hospitalist, as one example. The hospitalist might have a team of 5 people, so that alone can cause a lot of confusion from the start. One thing, the best quote I've ever heard about what it's like to be in a hospital, and I apologize, I don't know who said this first, but the person said it's like Alice in Wonderland, where everybody who's already there thinks that it's completely normal the way it runs, but everybody normal realizes that it's nuts.
Right.
So it is a bit like that, and if you can go into it with that mindset, people are still there for the right reasons, wanting to care for you, but the system can sometimes seem not logical.
So maybe you can explain the system, because I think part of the issue is, right, when you go into a hospital, emotions are running so high.
Yes.
And stress and tension. So you're not even dealing with just somebody who's sick.
Of course.
There are all these other crazy, uncontrollable emotions that are happening as well.
Right. So the system is, you come in, you get diagnosed preliminarily by an emergency room doctor. You need to stay overnight. So then your care shifts to the next team of hospitalists. One hospitalist, I should say, and maybe some other supportive players. Then you may have some specialists or multiple specialists helping along the way. One confusing thing is that people can change. So if the weekend comes and that one person is not on, you will see a different face. So that can be confusing. I would emphasize that so much goes on behind the scenes that patients are not aware of, so much communication, so much reading, that they should take stock that is going on, and I think the perception can be that it's not.
Right.
Part of what drives the perception that it might not be happening is that decisions can also change very quickly, and you might hear from someone in the morning saying one thing, everyone talks to each other and the plan changes, and then the next person you meet says something different, which...
That's extremely frustrating, because that's actually happened to us. And,
I'm sure.
And you're just like, what are you talking,
Right. Why didn't you clue me in?
So why does that happen? Is it better to just expect that sort of thing to happen, or be prepared that sort of thing may happen?
Be prepared that it's possible.
I guess it's good to know why that sort of thing happens.
Sure, and I like this because I encourage families and patients to ask questions in a polite way. Ask clarifying questions. So if it happens that a plan changes and you weren't expecting that, I encourage patients and families to simply ask, why did that change, in a nice way, because we're all human and we're all trying our best, and you want it to come across in the way that it's meant. Just why did that happen, so we can explain. A lot of times it happens because the first person the patient sees in the morning is the most junior, because that person is tasked with just making sure everyone is stable overnight and checking up on them, and may say something or be under an impression that's actually not the case, or once the more senior members of the team come in, they're considering some other thing going on, or the specialist and the generalist disagree and they're working it out, and it really depends on the specifics of each case, what's happening.
So is that something that's common that happens in hospitals? So in terms of you as a hospitalist, a patient comes in, right? Is there a certain kind of protocol in terms of like the kind of meetings you have or the kind of reports that you receive? Do you talk to the the nurse or the social worker, or so how does it kind of work where then you guys create a diagnosis or a treatment plan or whatever, and are you the one who's the one who delivers the information, so to speak? Or
every hospital is a little bit different in how they do it, but generally the intern and resident, if it's a teaching hospital, come in the morning and get report from overnight physicians. If it's a hospitalist, you get report from overnight about anything significant that happened. Talk to the nurses, hear reports from people who knew what happened. Then we all round in the morning, and what rounding means is going through every patient in a specified order. This is what the patient said in the morning, these are the vitals, this is the physical exam, these are new labs, these are images, here are all the problems ranked in order of importance, and this is what we should do about it. And a robust discussion can happen at that point, especially if someone's very complicated or you want to start a medicine that might have an ill effect.
So who's a part of that meeting?
So usually that is the attending, the resident, the student, and the intern. And if it happens to be a hospitalist, it may be the hospitalist and the PA. If it's in an ICU or somewhere where nurses are encouraged by the culture to join rounds, it may be the nurse as well. And then in my hospital, we happen to have separate what we call multidisciplinary rounds, where we all meet with the caseworkers, social worker, physical therapist, respiratory therapist, all to come together.
Wow.
And really give an update. And the point of that meeting is to say, what are barriers to getting this person out of the hospital, or perhaps what something nursing knows that the physicians don't know yet.
At what point do you contact their regular doctor, their PCP?
It depends also on the time of day. If the person comes in at 8 p.m., it's usually pretty hard to get the PMD that night. But ideally, it would be toward the beginning of the hospital stay, especially to clarify any medicines or sticking points that we don't know the answers to. And then throughout, depending on how sick the person is, and then at the end to give a heads up, okay, this happened, this is what we changed, and the person's leaving the hospital now.
In what ways can families best, I don't know, not prepare to go to the hospital, but you know, I'm sure in terms of like advanced directives, there are certain things I feel like people may not automatically realize they should have on hand.
Right.
That are critical.
That's a great example. If they exist, bring advanced directives, bring a medication list, and don't give it away. Perhaps make a couple of copies, because one thing that frustrates everyone is that you come into the emergency room, you give your medication list away, perhaps to a pharmacist or somebody, and then the rest of the teams actually don't get to see that list. And you would think that they would.
So there's no centralized computer database?
There is, but we are all taught to take our own histories, because otherwise it's a game of telephone, where you're kind of taught not to trust other people's histories. Always take it with a grain of salt. So the best care we are taught is to ask the same questions over and over again, as frustrating as that is for everyone.
And yes, that's actually funny, because it's true. That's why they do it. You're constantly answering the same questions all the time when you go.
Yeah. Because it could be lost. Something important could be lost in translation if you're getting it from someone else. So that's why we nag you all. And so that's why I say that about the medication list. If you keep one precious copy that you always have with the patient, then it can be shown to many people. And just being there as much as you can to speak with the doctors, I think.
What do you mean, a family member?
Yeah, a family member can really help, even if it's not a language barrier issue or a cognition issue.
Okay.
Basically to hear any news, because it's complicated and confusing and fast. I think an important thing to know is we all know that people aren't feeling well and emotions are running high in the hospital. And actually, it's important to know that the people who work there, that's where they work. So it's a lot, the tension really is one-sided, honestly, in that the patients and families are having a much different experience than the people coming to work.
Right.
And
sometimes I think we forget you're human, actually. You know what I mean?
Yeah, of course.
We're there, we're sick. Just help. Your job is just to help them. Just help them. You know what I mean?
Right.
I feel like.
And we do want that. And we do want that. So if there's something you're upset about, or you feel like is not being heard, I do think it's wise to be an advocate for yourself or for a patient, to speak up and be a squeaky wheel in a nice way, in a polite way, as best you can, because we are human and we want to come to your room. And I've seen some rare but dramatic examples of where the tension is so bad in between the family and the staff that it becomes really unpleasant, and no one is going to want to help, because of that human fact.
Right. So it's hard to, I mean, in those kind of situations, can you switch?
Yeah, you can request that, certainly request that, and that can be done, and hopefully it would never get to that point.
Right.
As long as everybody is open about what the perception is, I think most people can come to an understanding.
In my experience with my parents, for example, going into the hospital, it's never been an amazing experience, to be honest.
Right.
It's I feel like a lot of times we're chasing
Okay.
whoever, to try to get information. And maybe that's just how I'm perceiving it. I don't know whether, because I have a certain kind of timetable versus the hospital. So I'm just wondering, how can we better, how can we create a better communication line between families and the staff, knowing that the staff has their best interest in mind?
I think it is helpful for families to know that the timeline of the hospital is different from most people's timelines. And there's just so much conversation that usually does not happen at the bedside. This is I shouldn't say new, but this is an effort in some hospitals to bring rounds, our meetings in the morning, back to the bedside in front of patients and in front of families, because one big benefit of that is that you see how much thought goes into every decision that's being made. And I think if families realize that that is happening, and sometimes the communication might be delayed a bit so that we have more information to share once it comes in,
Right.
after speaking to a consultant or something like that. I think it's like anything in life. If you are open and communicate clearly and say, I'm upset about this because X, Y, or Z, in a mature way that's not confrontational, I think that would go a long way. And on both sides, to explain what the process is and perhaps say, okay, I'll get back to you this afternoon, and be flexible about the time.
And who would we go to? So say we want to know what the protocol is or what we should expect.
Right.
Correct.
So one good thing to do would be to ask the nurse, who is my hospitalist today? Or who is my primary MD point person that I should be talking to? Or PA point person that I should talk to today? Realizing that it could change on a day-to-day basis. And then you can say, do you mind paging that person for me, and saying, I would love to talk when they get a chance.
And that's effective.
Yeah, yeah, it is effective.
Because it's funny because we don't know that we can even do that a lot of the times, right?
Yeah, you're right.
We just feel like we're kind of hostage
Waiting.
there, and we have to wait.
Right. And it may, if you do that and say, do you mind, I'm around, you may have to wait if somebody else is having an emergency. And it's good if the doctors are not always around your family member in the hospital. It really is good. But if you're a bit flexible about the timing of when the MD can come, then they will certainly come to the room and give you updates. And can write it down. My hospital happens to have a whiteboard where we write down my last name and my team's names, so that when I walk into the room, they say, oh, Heuzey, I know you, so that they know I'm the primary person for them. So that can be helpful. And if the hospital doesn't have that, write it down.
Mm-hmm. What do you love most about your job?
I love talking to people and really having them tell me very deep, important information about themselves, and trusting me that I'm going to do my best to make them feel better.
It's interesting because it's a very different kind of doctor, right? It's your patients aren't your patients for life or for years, like PCP or whatever.
Right.
But they're rather fleeting.
Yes.
So it must be kind of a very different experience, kind of doing your best to heal somebody on the short term.
Right. It can be more intense because of where they are and how sick they are to have to be in the hospital. So even though I don't get to see most of my patients over and over, and there are some people that I have seen multiple times, unfortunately, but even when I don't, it's something that person will probably remember for the rest of his or her life, having been hospitalized and sick and feeling terrible. And if I can help him or her through that time feel better, that is important to me.
I had talked to a geriatrician about being in the hospital. And it's funny because he was like, the hospital is the last place you want a person to be, especially an old person.
Yes. They're not, because you tend to sit in a bed or lay in a bed in a hospital and not move very much, which puts you at risk for skin breakdown and constipation and pneumonia and clots. And delirium was probably something the gerontologist was thinking about the most. Delirium is a state where you are confused about where you are, and what year it might be. It's waxing and waning, where you're going in and out of consciousness. You might be sleeping during the day and awake at night. It could come with hallucinations, which can be quite frightening for the patient and for families.
Is that just from being sedentary?
It doesn't help to be sedentary. It's from being in a different environment that you're not used to. It's from being sick. So elderly people are more at risk for delirium. So all these, and we wish we could have people walk around more often than we can physically do. But with people being at risk of falling and not enough people to be there many hours out of the day to help them walk, it's a bit of a necessary evil. And I think that's what he meant by not wanting your loved ones to be in the hospital if they're older. Then it's time to work on leaving the hospital. And some people get really nervous to leave the hospital, but you have to think about the downsides. I didn't mention infection, getting hospital-acquired infections that are more resistant to our typical antibiotics is another big one.
Wow.
So when it's time to leave, it's a good thing.